Okay.
సరే నేను ఇది పెడతాను, అప్పటిదాకా ఓపీ చూస్తాను నేను.
Ma'am, we are live.
I will join again at 8:55.
Okay.
We also have our speaker Hari joined.
Hi, good morning, Dr. Hari. You're in US right now?
Cayman Island.
Good to know that. Funny, if you started the broadcast, people will start attending, right? Joining.
People are joining, Adi. As of now, around 145 join. We'll wait for 20 minutes.
Mm-hmm.
Hi, Hari.
Madhuri.
So, hello for all the attendees from around the globe. So, we will be starting with our session by 9. So, please ask your friends to join the session. So, till then, please stand by. Thanks. Hello everyone. We request you not to drop your details, especially personal details and your AAPC details. We don't want to have any of the details on the chat. So please do not drop the details in the chat box. The attendance is auto captured. So please don't post any of your details in the chat box. Thank you. Hello to all attendees. Please do not share your details here. We do not want to have your details on the chat box. Please don't share. Yes, there is someone who is helping us. Thank you. Yeah, so please don't share your details. Please don't share your personal files or anything. So good morning to the ones who are joining now. So please do not share your details, and we will get started in a moment. Please ask your friends to join the meeting. If anyone didn't join, please drop messages in your office groups or friends groups or anywhere that you are a part of. Thank you. Over to you, ma'am.
Thank you, Mani. Hey, good morning, everyone. Happy Sunday, Saturday, all of you. And I know everybody are excited. The first of all, as a president of the Hyderabad local chapter, I would like to say we missed last month chapter meeting due to some technical reasons. However, we are gonna come back with the great energy and yet again another topic. I know I've been coding for 25 years now, but every time when we get into the sepsis, oh my God, where is my flow chart? Where is my official coding guidelines? Am I coding it right? Am I reading it right? Am I reading the septicemia correctly? Am I reading the source correctly? Am I reading the organ failure correctly? Oh my God, too many questions, isn't it? So yet again, we from chapter would like to thought like, okay, let's talk about the deep dive into the sepsis in detail from a clinical perspective, from a documentation perspective. I know probably people who are here for the past 2-3 years, we've already heard Dr. Krishna talking us about sepsis and giving us a more enlightenment to it. But yet again, with another energy, we are all here with Dr. S.H.N. Murali Krishna. And it's a proud moment for me to introduce, it's an honor for me to introduce Doctor, who is a retired wing commander from Indian Air Force, the internal medicine, who's also the infectious disease specialist. He's a primary aviation medicine specialist. He's also an executive MBA in hospital and healthcare. He's an eco-physician, he's certified in medical law, and he's also an assistant associate professor for a medical college. Having all these accolades, he's a member of Army Medical Corps. As I said, he's a retired wing commander. He's a member of Association Physicians of India. He's a member of Indian Medical Association. He's also a member of Society of Infectious Disease and been serving for more than 17 years now. And he after coming out from the Indian Air Force, he's working as a consultant in a hospital, in a Sri Sai Holistic Hospital, Nizampet, Hyderabad. And he also sees patients in Krishna Specialty Clinic. Probably I can give you, Funny, would you like to bring out to know the doctor's slide for everybody, where all of you can reach out to Dr. Krishna from the WhatsApp group link. Probably will share you. Any questions, any emergencies, you can absolutely feel free to reach out to him and join his WhatsApp group for any of the insights. And it's a proud moment for me to introduce and welcome Dr. Krishna for our wonderful knowledge-oriented session today. Welcome, Doctor, and over to you.
Thank you, ma'am. Thanks for the introduction. And shall we start away directly about the talk?
Yes, Doctor. Yes, please.
The
But Doctor,
presentation-
would you mind sharing your WhatsApp group link within for our people here in the chat group so that they can join your WhatsApp group for any help and support that is required?
Yes, ma'am. I think people are joining from all over the world for this presentation. But anyone who is having any kind of query, if they want any second opinion or anything, they can WhatsApp me. In my free time, I will definitely try to help them. And if someone is in Hyderabad and they want me to see the patient also, I can extend my health profession to them.
Thank you so
You
much.
can share the group.
Thank you so much for that.
And how about the presentation? Should I share my screen or how?
I can do the honor for you. I can share my screen. And one second, I'm just sharing my screen.
How about changing slides?
I can do that for you. Funny, can you give me the access to share my screen?
You have access, ma'am. Just a moment. Can you
Yeah.
check now?
Yes.
Shall I share my screen?
Even that works, Doctor.
Yeah.
I need some guidance to share this.
Okay, no, I'm done. I'm done. Can you all see my screen now?
Yes, we can see it.
All right, thank you. So as I said, here is the presentation, and we can go ahead.
You can keep in the screensaver view.
Okay.
You can skip the slideshow.
Mm-hmm. Okay. So when I'm presenting it, isn't this now going into the screen?
Hit F5, ma'am.
Is it okay?
No.
Please get into presentation mode by hitting F5 so that we'll have full screen mode.
For me, it is gone. Funny. Funny, would you mind share the screen?
Yeah, I will. Just a moment. Sharing my screen. Hope it is visible to everyone.
Yeah.
Yes, it is.
Okay.
Shall we go ahead?
Yes, Dr.
Yes,
Krishna.
No, good morning, everyone. Thank you, Adi. And I will straight away go to the topic. And today's our topic is knowing something about sepsis. And the motto target about the presentation, at the end of the presentation, I want everyone to understand the terminology that we use. Okay, that is the main target of this lecture. And depending on the time, we will extend and learn in detail. Slide. Next slide. Yeah. And during this lecture, we will learn about sepsis. And coming to the epidemiology part, and the projected global burden is 2% of hospital admission, but the census is up to 2,000. But as of now, till 2020, the burden has increased. It is now 6% of the hospital admissions. And every year, around 500 people are having mortality with for every 1 lakh population. And the burden has increased over last 2 decades from 2% to 6%. So it's time to learn something about sepsis. And next slide. This is the only screen, this slide, which we are going to learn about. I want everyone to learn each and every term what is being shown in this slide. At the end, everyone has to understand when I say it is infection, what is infection. When I say it is sepsis, how different it is from infection. When I say it is septic shock, how different it is from other terminology. Coming to the first terminology, systemic inflammatory response syndrome. Next slide. Inflammatory response syndrome. There is the word says that there is no infection involved in this systemic inflammatory response syndrome. It can be a non-infectious thing, and we diagnose a person to be having SIRS, systemic inflammatory response syndrome, when any of those two of the following, like when temperature is more than 38 degrees centigrade, when the heart rate is more than 90 per minute, when the respiratory rate is more than 20, and the leukocyte count is more than 12,000. These are the 4 criteria. If any patient who comes to us and if any 2 or more than 2 of the criteria are met, then we will call the individual to be in SIRS. He is in systemic inflammatory response syndrome. When the patient is having SIRS, now if the patient is having a focus of infection, then we call it as infection. SIRS plus any focus of infection, then we term it as infection. Now, what is the difference between infection and bacteremia? Next slide. Infection means when a organism, particular organism, say it can be bacteria, virus, fungi, or anything, when it is invading any of our body tissue and growing, it is called infection. It can be in a particular organ, or it can be through entire systems, multiple systems. We call it as infection. How different is infection from bacteremia? Infection is like, as I said, it is localizing a particular organ or tissue, whereas bacteremia is finding a viable bacteria in the blood. The infection may or may not be found in the blood, but if the organism has access to some tissue, then we call it as infection, and we find that source of infection in the blood, then we call it as bacteremia. Now, in infection, it can be bacteria, virus, fungi, parasites, or anything, whereas in bacteremia, it is only the bacteria which is found, not virus, fungi, or parasites, or anything. When I say it is bacteremia, I mean to say that I found some viable bacteria in the blood. When I say it is infection, I may or may not found it in the body, in the blood, and it can be any of the type of infectious or microorganisms, bacteria, virus, fungi, or anything. Next slide. This is bacteremia. This is what I have discussed. Next slide. Now coming to sepsis and septic shock. Now, if we go in the chronological order, we call it as SIRS when there is some response to any of the trigger that could be infectious or non-infectious. That trigger leading to having some response, SIRS. At least 2 criteria what I have said earlier, that will become SIRS. With focus of infection, we call it as either infection or bacteremia. Now, when do we call sepsis rather than calling as infection or bacteremia? When do we call sepsis? When there is each and every word in the definition has certain importance. When it is life-threatening, when there is organ dysfunction, and when there is a dysregulated host response to the infection, then we call it as sepsis. Some may term it sepsis when the infection is more severe. No, it's not like that. When the infection is, the response of the body is dysregulated. For example, I would like to quote a crude example. If a mosquito fly on our hand, what do? We just like to tap on the hand to avoid infection from that. But if the same mosquito flies on the hand, if we beat it with a stick or anything, this is a dysregulated response. We need to respond, but our body is responding exaggeratedly, dysregulated. And having a dysfunction, having the disease to us because of the response, not per se just because of the infection. The dysfunction is because of the response of the body. Sometimes the infection might cause a little damage, but the response from the body, the immune response from the body might cause more damage to us. It is called sepsis. Okay. Now, when do we call septic shock? In cases of sepsis, patient, most of them are dehydrated. To maintain the vitals, we need to transfuse crystalloids and sometimes colloids or sometimes even blood, depending on the condition. Even when we, after fluid resuscitation, if the patient is not responding, and to maintain the mean arterial pressure more than 65 millimeters of mercury, and we need to add some inotropes to get the mean arterial pressure, even when we fail with fluid resuscitation. Then we call it as septic shock. So septic shock take-home message is using inotropes when we can't maintain the map, even with the fluid resuscitation, with all criteria meeting sepsis, then we call it as septic shock. Next. Yeah, this is pathophysiology point of view. It might go deeper, but to highlight, whenever there is a host pathogen interaction, we have two kinds of responses. One is pro-inflammatory and one is anti-inflammatory. When they get balanced, we have a normal response. If the pro-inflammatory or anti-inflammatory response is more, when this response is dysregulated, when the pro-inflammatory and anti-inflammatory, the host factors will have anti-inflammatory. The pathogen will trigger some inflammatory response. If this is balanced, if the patient gets proper treatment, timely treatment, then he will recover. Sometimes the anti-inflammatory response from the host factors that can vary as per the age, his genetic factors, other risk factors, other comorbidities. This anti-inflammatory response may vary. When this is dysregulated, we just land up in the sepsis. Next slide, please. Yeah, as part of the sepsis pathophysiology, sometimes there is increased coagulation and the patient will land up in strokes, patient having tissue hypoperfusion, and this leads to organ failure. And next slide. I will also like to add a few other terminologies like severe sepsis. When do we call severe sepsis? When there is sepsis, again coming in the chronological order, cysts, infection or bacteremia, sepsis, and then septic shock. In between sepsis and septic shock, there is severe sepsis. In severe sepsis, there is organ dysfunction. When the patient lands up in sepsis and then he is having 2 or more organ dysfunctions, then we call it as severe sepsis. Severe sepsis, when we are unable to maintain the required map with fluid resuscitation, we call it as septic shock. Now, septic shock, to maintain the mean arterial pressure, we are starting the patient on inotropes. Even after starting the patient on inotropes, the patient not responding, we are unable to maintain the vitals, his hemodynamic stability could not be maintained, then we might call him as having refractory septic shock. When there is refractory septic shock, then we need to reanalyze, we need to have a resurvey to find the other causes. Like last week, I have to see one patient who landed up in the emergency room. Immediately when he landed up in the emergency room, he has fever and his vitals could not be, his BP was less than MAP. And then initial fluid resuscitation was done and the inotropes were started. His MAP could not be maintained with single inotrope, and then it could not be maintained with 2 inotropes. Then he has to maintain on 3 inotropes. Even with 3 inotropes, he could not be, his MAP could not be achieved. Now we can call it as refractory septic shock, but in this case, what happened? We need to re-explore. And on reanalysis in the emergency room itself, we found that he is having some obstructive shock. Obstructive shock means he had pericardial tamponade. Pericardial tamponade means the heart could not expand, could not contract because of the increased fluid. Pericardial effusion we call, when it is more severe and the heart could not contract properly, we call it as tamponade. After doing pericardiocentesis, the patient's inotropes were decreased in less than 2 to 3 hours. Without inotropes, he could be managed. So always we should reanalyze whenever we are not getting proper answers to our clinical assessment. So this is the flow of SIDS, infection, or bacteremia, sepsis, severe sepsis, refractory septic shock. And there are certain tools to assess the severity of sepsis. Quick SOFA score. Go back to the previous slide. Quick SOFA score. This is a bedside tool where we analyze the patients in emergency room. When the patient comes with altered mental status, when his respiratory rate is more than 22 and the systolic blood pressure is less than 100, we analyze to be having that patient might progress to sepsis. When 2 or more of these 3 are there, then we can call it as having the patient has impending sepsis. Of course, the focus of infection has to be there. And then if the patient SOFA score, when the patient is shifted to ward or when the patient is shifted to ICU, then we will be having further deeper analysis of assessing the sepsis. That is sequential. This is quick SOFA. That is quick sequential organ failure assessment. Next slide. When the patient is shifted to ICU and when we have other investigations, then we can have the detailed evaluation of certain organs. Like this is called sequential organ failure assessment. The earlier one was quick SOFA and this is SOFA. Here we analyze various organ function. There are certain parameters, like for neurological examination, assessment of the cyst organ, we assess the Glasgow Coma Scale, his sensorium. For respiratory system, we analyze the PaO2 by FiO2, which we get these values by doing the ABG. And central cardiovascular system, when the map, depending on the map, we assess and give the score. For renal system, depending on the urine output and depending on the creatinine levels, we assess the organ function. And liver, based on the bilirubin values, we assess its function. Based on the platelet value, we assess the hematology system. So there are certain parameters we analyze different organ function when the patient is having sepsis and to assess the associated organ dysfunction. Next slide. So this we have already discussed. That patient when comes with suspected infection, we initially go with Q-SOFA, and the Q-SOFA says that the patient is not having sepsis. But if we should not always go by these scores. See, for the patient who is coming with suspected infection, his Q-SOFA score is less. If the clinical suspicion is there, we should continue monitoring for progression to sepsis or septic shock. If the Q-SOFA is there, then we need to have a full SOFA score where we need to have detailed analysis of the organ function. And then comes the sepsis and septic shock. Next slide. And I will not go in much detail about the sepsis management. My motto was to understand you about the terminology. When we speak to each other, when I say a word, you understand what I mean to say. And the management has different roles, like initial resuscitation, diagnosing it, like what is the source of infection and how severe it is. And depending on that, giving the fluid therapy, antimicrobial therapy, and sometimes steroids. I will like to focus on steroids here. In sepsis, what we have discussed is that it is dysregulated response. It is dysregulated response. To decrease this dysregulated immune response, we give corticosteroids to control the immune response, simultaneously giving the antimicrobial therapy. Because some people will have a doubt, the corticosteroids are immune suppressant, the patient is having severe infection, they are calling it as sepsis, why the steroids are given. The steroids are given to regulate this immune response. Next slide. The code, I think if any new changes are there, I think Mrs. Adi will correct this. But what I know is these are the sepsis and septic shock codes. Next. Yeah, I have 5 more minutes. If anyone has any queries to discuss, I will be happy to clarify the doubts.
Funny, can you go to the next slide where we have a scanner for us to connect with the doctor? Yeah. Thank you so much, doctor. I think it's wonderful presentation, and I think when I compare from your previous presentation where you have given us more insight about the condition, pathophysiology of it, I think today before going into the clinical documentation, I think this is absolutely required for every coder to understand the terminology, and it will also help us write a query to the physician without bugging them. I know, because when we are talking about clinical documentation, we do have multiple queries and the formats that comes in to seek help from the physician. If anybody has any questions to Dr. Krishna, I would read it out for him.
Not just related to sepsis, if anyone want to utilize the next 5 minutes for clarification of any kind of medical doubts, which you feel might benefit everyone, you can even go with those queries or questions. Even not just related to the sepsis, any of the medical queries what you feel that everyone will get benefited. If anyone has any personal doubts, they can WhatsApp me after joining the group. So I'm open for the questions.
Guys, anyone has any questions? How the treatment, doctor, there's a question. How the treatment differs from bacterial and fungal sepsis?
Differs from?
How the treatment differs for bacterial and fungal sepsis?
In bacteria, we give antibiotics, whereas in fungal infection, we need to give antifungals.
Okay.
This is the only. But to elaborate more, when a patient is having fungal infection, it is not common for a patient to have fungal infection. If a patient is having fungal infection, we need to analyze, we need to treat, and then we need to analyze the immune status. Patients who are diabetic, who are using immune suppressants, malignancy patients who are on chemotherapy, elderly age people, they are prone for this kind of fungal infection. If any patient comes with probable fungal infection, simultaneously you have to treat and evaluate the immune status also. Bacterial infections we see more common, but fungal infections are not common. Treating might be a little difficult, fungal infections, but it is less common, fungal infections, when you compare with the bacterial. And coming to sepsis point of view, gram-positive bacterial infections are more common. These days, gram-negative are increasing, but as per the statistics per last decade, gram-positive are most common.
Okay. There's one more question, doctor. Without linking organ dysfunction, can we go with sepsis and dysfunction? So here, this question is again from a documentation perspective, when the physician doesn't talk about the organ dysfunction is due to sepsis or any dysfunction. So how do we, correlate that?
No, if the patient organ function is preserved before this insult, then we can presume that this organ dysfunction is because of sepsis.
Okay.
Otherwise, it will be difficult to comment directly whether it is related or unrelated. But for clarity, if you as a coder or anything, you can ask what is the status of previous his organ function. Like if a patient is having acute kidney injury and the doctor says this is because of this sepsis, then you can check for the last 1 month, last 3 months creatinine reports if they are available. If they are normal, then the problem of acute injury is because of this secondary to this sepsis.
Okay. There's
But
one
if
more
a patient,
question.
yeah.
Yeah, there's one more question. Is there any local medications for sepsis?
Local means I know about only allopathic medication. I did not understand about what is local.
Local medications in the sense, maybe I'm not sure whether the question is referring to topical.
Any patient. No, now since we all know about the terminology, when you call a patient as sepsis, I definitely prefer the patient to treat as inpatient rather than outpatient. And the local medications means if the patient is having sepsis, then it is better to get admitted and better to give parenteral medications,
Okay.
not even tablets.
Okay, there's one more question. Is blood culture mandatory to confirm sepsis?
No. Blood culture sometimes, not sometimes, most of the times they don't grow anything. So it is not mandatory that the blood has to grow something to call it as sepsis.
Okay.
One
In
thing
view,
I would like to say, there are
yeah.
few markers of sepsis like procalcitonin. Like last time, the earlier question says bacterial and fungal infection. In bacterial infection, we can do procalcitonin, which is generally raised in bacterial infection. In fungal infections, we do galactomannan, beta-glucan, these. They are raised in fungal infections.
Okay. In view of time, I will just take one more question, doctor. But again, I will reach out to you for a separate, forum, because I want to address all the questions from my team. The last question that I will take, sir, could you please explain about urosepsis? I think because this is one question that every coder will have. When physician documents urosepsis, how do we read it as?
Urosepsis means these are two parts. The sepsis part, where the primary focus of infection is urogenital tract. I did not find much difficulty in understanding the urosepsis part. Now you all know about sepsis. When someone call it as urosepsis, the focus of infection is urinary tract. It could be kidneys, it could be the bladder, or it could be the external.
Okay, so can we read it as UTI? Can we read it as UTI, urinary tract infection?
Now, since we are more particular about terminology, when you say UTI, then I have to say whether it is upper UTI or it is lower UTI. Then I have to comment on whether it is complicated or it is not complicated. Since as a coders you are more specific to the terminology, if I say infection, then it is infection. When I say it is respiratory tract infection, when I say it is urinary tract infection, it is more apt. Similarly, when someone asks UTI, the specific questions like when I write my diagnosis as UTI, I specifically mention UTI, upper, oblique, lower, whichever it is, and then whether it is complicated or whether it is not complicated.
Sure. Thanks, doctor, but I still have few more questions. Probably I will reach out to you, to get the answers. And we will publish all these question and answers from you, in our LinkedIn as well. We would like to tag you there. And is it okay if we can share your presentation with all our team members who can get benefit to understand the more terminology?
Yeah, definitely. I will share the presentation. Even if someone has any specific doubts, they can post me on WhatsApp.
Thank you so much. Thank you so much for your valuable time today, doctor. And I know we still have some more questions, but we will reach out to you to get your insights of it. And then we will publish them onto our local chapter LinkedIn page.
Thank you, ma'am. Thank you very much.
And I hope everybody had a great opportunity to meet you and listen to you today. Before we go into the documentation aspects, we definitely got a better insight on the terminology. And thank you so much. And have a great day, doctor.
Thank you, ma'am. Thank you very much.
Thank you. All right, guys. Isn't it a wonderful session? And I could see all the claps coming in. Yes, it's a great insight to understand the clinical aspect, and from a doctor who's actually treating patients with that conditions. Now what? Let's move on to our next segment that we're talking about, the documentation. Now we heard the doctor, let's hear another doctor with some coding expertise. And this is none other than Dr. Hari Oblesu. And he comes with 17 years of experience across clinical practice and US healthcare. And Dr. Hari brings a rare blend of clinical depth and the coding precision. Currently, he's serving as a manager revenue integrity coding at Health City, Cayman Islands. Dr. Hari has led multidisciplinary teams in coding audits, DRG validations, CDI initiatives, denial management, and inpatient claim adjudication. His expertise spans across ICD-10, CPT, PCS, appeals, and payer policy navigation, covering Medicare, Medicaid, managed care, and commercial plans. Dr. Hari is known for connecting clinical insight with documentation integrity, making him the perfect voice to decode a complex topic like sepsis, not just as a condition, but as a coding and compliance challenge. I take this honor to have him walk us through with the intersection of clinical reality and the coder responsibility. So let's take this moment and let's welcome Dr. Hari to share his insights on the clinical documentation and coding of the sepsis. Over to you, Doctor. Dr. Hari.
Thank you, ma'am, and thank you, Dr. Krishna, for sharing his amazing knowledge on sepsis. Like almost all doctor explained about a clinical perspective and all. Maybe here and there, my statements are going to be contradict with that whatever Dr. Krishna's statements. That intention may be purely towards the coding and US healthcare environment only, not to the clinical perspectives. Then now, here, we are coders. We know what we are going to do. Then when we ask the definition of medical coding, everybody will say like it's a translation of what doctors' documentation into alphanumerical codes and all. But we need to change the definition of medical coding, like whatever it may be the clinical documentation, that in spite of physician documentation, we need to redefine the coding definitions. I say transforming the clinical documentation into appropriate alphanumeric codes, which was defined by ICD-10-CM. Okay, then here to translate or transforming the clinical documentation or to assign an accurate code assignment, then accurate clinical documentation also is very, very important. Then to know that the documentation, either it is accurate or not, we need to have a knowledge. Every coder need to develop certain knowledge about, at least to some extent, like what is the natural history of a disease, what the signs, common signs and symptoms of a particular disease, then how the disease progresses from stage to stage, and how it is going to be diagnosed, and what would be the treatment. Then only we can understand that the physician would documentation appropriately. Either he documented or any documentation lacunas or gaps in physician documentation, and we can easily understand that documentation, and we can use a physician queries to get an appropriate documentation on where the documentation ambiguities and lacunas was there. Then only it's possible to assign an appropriate code for that condition. Then let me share my screen. Just hope my screen. Guys, are you able to see my screen?
Yes, Dr. Hari, we can able to see it. We are all able to see it.
Here, this is the first page of our ICD-10 coding guidelines. First page, first and foremost page. If you go to the after coordinating parties, cooperating parties of ICD-10-CM, there is a statement. A joint effort between a healthcare provider and a coder is essential to achieve complete and accurate documentation, code assignment, reporting diagnosis and procedures. The importance of consistent, complete documentation in the medical record cannot be overemphasized. Without such documentation, accurate coding cannot be achieved. Here, usually the diseases like sepsis and all, most of the times they are not a part of outpatient services, outpatient conditions. Whenever a patient diagnosed as a sepsis or suspected as a sepsis, patient has to be admitted as an inpatient settings. When it comes to the inpatient medical record, there was a different entities in the medical record, like in emergency notes, ER notes, HNP, progress notes, consultation notes, discharge summaries, some therapeutic services, some diagnostics, and everything. Then we need to read each and every page of the documentation and we need to code it appropriately. Then again, suppose a physician visited the patient and in first day, or like first and foremost, either ER documentation and HNP, he will document like for one condition, he may document like 4 or 5 diagnosis codes, diagnosis conditions for one symptom. That might be it's a differential diagnosis. When it progresses to the discharge summary, the documentation progresses towards the discharge summary, only few diagnosis codes will be appear in the discharge summary. But based on the complete documentation has to reviewed, it was like a misunderstanding from the most of the coders, and they are arguing that this sepsis or some other diagnosis code was documented in the HNP. We need to code it for it. That is the wrong concept. First, we need to remove it from our mind. Suppose physician documented at the beginning as in a differential diagnosis code, when he visited the patient in next time and second day, third day, that the sepsis was not appearing in the medical record means it was ruled out. We need to understand in that way only. We need to know the scope and limitations of each and every documentation, HNP, progress notes, and like discharge summaries and everything we need to understand and we need to code it appropriately. Then again, ICD-10-CM official coding guidelines states that the assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient to code assignment. Code assignment is not based on a clinical criteria used by the provider to establish the diagnosis. Then this is the statement which was appears till 2023 or 2022. Then ICD-10-CM cooperating parties added another statement to this particular entire guideline, stating that when there is an ambiguity, then it's coder's responsibility to raise a clarification or physician query to the provider to get a clarification on a particular condition. Then now, as shown on this particular slide, coding is not just about checking a boxes and entering codes into the whatever it may be, or encoder or 3M. Then it's about just translating the clinical reality into the codes, whatever it may be, ICD-10 codes. Okay. Then in continuation to the same guideline, like in clinical criteria guideline, then there is some additional inputs in coding clinic and CMS. Then the code assignment is based on the documentation by the physician rather than the particular clinical definition or criteria. This guideline and the resulting coding clinic advice stresses the need for a process of validating a clinical condition prior to the assignment of a ICD-10 code. Then CMS states that all the codes, whatever we are going to assign, there has to be in a supportive with the clinical evidence in the medical record. Unless if there is no support, like if there is no clinical evidence or clinical support in the medical record, then though we coded based on the physician documentation, they are going to be denied. Then it's a rework to the coding or rework to the hospital a provider where they need to go either review the entire medical record, or either they accept the denial or they appeal the denial. It's unnecessary rework to the provider. So we need to validate appropriately before assigning ICD-10 code and send it to and submit the claims. Then when a particular practitioner documents a diagnosis that does not appear to be supported in the medical record by clinical indications, then query the provider or address it through a escalating process based on your facility guidelines. Don't blindly assign a codes for conditions like major conditions like sepsis, respiratory failures, heart failures, without any supporting clinical evidence in the medical record. Then, to deep dive into this particular topic, then we need to understand like certain topics like SIRS, then hyperlactatemia versus lactic acidosis, then SIRS versus sepsis, then sepsis subsets like a sepsis, severe sepsis, and septic shock. Then the criteria like a sepsis, sepsis 2 and sepsis 3, how they defined in historical basis. Then we need to understand the differences between SOFA and QSOFA and its limitations, and when we need to use and how to calculate the SOFA score. And we need to understand the coding guidelines. Many of us, because it's in a first and foremost chapter, we'll read very thoroughly and we understood the coding guidelines. So my total concentration on today's webinar is up to SOFA and QSOFA, how to assess the SOFA score and how to decide it, either the physician documented appropriately or not. If not appropriately documented, what to do. Will be most of the time will be I'm going to spend on these particular topics only. Then before going to sepsis and remaining septic shock and all, just we need to understand and what is an inflammation and what is an infection. Then inflammation is a body's response, like what Dr. Krishna explained. Inflammation is a body's natural response to protect against a harm. That harm might be either it may be non-inflammatory or either it may be injurious or something like an ischemic episodes also. Sometimes this inflammation, the same parameters what we are going to be considered as an inflammation, the same response to an infection also. That's why we need to understand that inflammation and infection. Once we understand the difference between inflammation and infection, then we can easily understand the SIRS versus sepsis. Then this inflammation may be acute inflammation, which is maybe like a, due to sudden, it will be sudden in nature and it will do rapid response. Then there will be a chronic inflammation due to non-eliminating process of acute inflammation. Then this inflammation can be identified with the help of certain parameters. Those are going to be called as inflammatory parameters. Those are like a CRP, procalcitonin, leukocytosis, elevated ESRs, and like a tumor necrotic factors, interleukins, fibrinogen, and there are some other inflammatory parameters also there. Then after inflammation, then try to understand the SIRS. SIRS is defined in 1972 by American Society of Chest Physicians and Critical Care Medicine Society. They defined SIRS as a systemic inflammatory response syndrome. It's a body's response or a human body's response to an inflammation. Then especially then when we are calling it an inflammation, means it's a non-infectious process. We used to call it as in most of the times it's an insult. That insult may be like due to major traumas or surgeries, malignancies or burns, some pancreatitis, some ischemias like a mesenteric ischemia and even myocardial ischemia. Then some aspirations like a chemical aspirations and some peritonitis. All these things comes under non-inflammatory processes, non-infectious processes, sorry. Then how we need to identify the SIRS, systemic inflammatory response, in our medical record, and how to code it appropriately. Usually this SIRS is going to be supported with 4 parameters as per this society. Those are either hyperthermia or hypothermia. That means either temperature is, we'll say it is in 100.4 because we used to use Fahrenheit temperatures in our local environments. Then either it may be 100.4 like in a hyperthermia, or less than 96.8 as in a hypothermia. And there should be a tachycardia. Tachycardia means like an increased heart rate of more than 90 beats per minute. Then there will be an increased respiratory rate, be greater than 20 breaths per minute, or arterial carbon dioxide levels should be less than 32 mmHg, which will be unique. You can identify this PaCO2 in your ABG reports. Then again, either patient should be might have either leukocytosis or leukopenia. Leukocytosis means an elevated WBC count, which would be more than 12,000, or leukopenia means it's a decreased WBC count that should be less than 4,000. These are the 4 parameters which was defined by American chest physicians for a part to define the SIRS. Then they defined another criteria based on these 4 parameters. That clinical record or clinical documentation should be evident or should be supportive, at least 2 parameters in these 4 parameters, and there should be a documented insult or non-infectious process. Then only we need to code it as an SIRS with an R65.10 series codes. If non-infectious process or a cause for an elevation of these parameters or abnormalities of these parameters are not documented in the medical record, then you feel that medical record documentation is in ambiguity, then you need to raise a query to the provider before assigning the code. Okay, now slowly we'll move to SIRS to infectious process. Before going to infections and sepsis and all, there is another condition which we need to know to understand the sepsis in detail. That is lactic acid. We need to understand that lactic acid normal levels as 2 millimoles per liter. Lactic acid is one of a byproduct of the routine regular metabolisms, especially anaerobic glucose metabolism.
Oh,
At the very most. So I'm going to see that probably.
Usually lactic acid is produced from the many tissues in the body, especially like skeletal tissues, heart, and skeletal tissues means here muscle tissue, and some intestines. Many organs are going to produce an lactic acid. Usually, you need to understand a tricky point here. Lactic acid usually going to be released at the level of 20 millimoles per kg body weight by various tissues in the body. Suppose if you do aggressive exercises or walk exercises and all, then lactic acid is going to be produced more than 20 millimoles per kg body weight. Then usually if you take approximately like an adult human being, that per day it is going to increase, like lactic acid production is around 1000 to 1500 millimoles. But whenever for a normal person you check that lactic acid levels, it should be always less than 2 millimoles. What's happening? Like 1000 millimoles of lactic acid is going to be secreted by the body. Then blood is having only 2 millimoles, less than 2 millimoles. Then this lactic acidosis is one of the precursor for gluconeogenesis, which was processed under in the liver. It's a anaerobic glucose metabolisms and all metabolisms. It is going to be used as a precursor, and it is going to metabolize into pyruvic acid and water and some. It's a very big topic again. We don't want to go to there. We need to understand it. Then again, remaining lactic acidosis is going to be excreted through our excretory system. Suppose, why lactic acid is important to discuss here? Whenever a patient having a septic shock, lactic acid is one of the standard parameter to define a patient with septic shock. Then, patient should have hyperlactatemia. When we are going to call it as a hyperlactatemia, we are going to say it is when lactate levels are greater than 2 millimoles per liter, then it is going to be called as hyperlactatemia. And whenever it is greater than 4 millimoles per liter, it is lactic acidosis. Even I think we have a code for metabolic acidosis and acidosis codes. While assigning it, you need to refer the lactic acid levels. If it is really lactic acidosis is coding, you are going to code a acidosis code. You need to refer whenever it is greater than 4 only. Otherwise, you need to code as a hyperlactatemia only, not as a lactic acidosis. Then this is also one area where lactic acidosis codes are going to be denied. Okay, then we'll think about what is the reason for lactic acidosis and hyperlactatemia. There are two reasons: either excessive production, whatever it may be, the produced excessive than more than 20 millimoles per kg body weight, then that body is producing lactic acidosis, the one reason. Then another one is impaired lactic acid clearance. It may be a liver impairment or kidney impairment. These are the two reasons for having a hyperlactatemia and lactic acidosis. Then already we discussed about inflammation, then we'll discuss about infection. Infection involves an invasion and multiplication of microorganisms, like what Dr. Krishna explained. Then there should be a pathogens like bacteria, viruses, fungi, and parasites. Then the signs and symptoms, it's very similar to SIRS, and depending on the severity and type of the pathogen and location of the organ involved or affected, localized infection. Then based on that, symptoms can be classified into broad two categories. One is a constitutional symptoms, another one is a localized symptoms. Constitutional symptoms, most of every patient will have a fever, weakness, fatigue, and all. And localized symptoms, like based on the organ involvement, patient will have either digestive systems, patient might have digestive signs and symptoms. Then respiratory, then patient might have cough, cold, like the respiratory symptoms. This is an infection and inflammation. Then we'll move to proper sepsis now. Sepsis generally, it was a very long process. It was evolved in a detail. And these are the three basic milestones we need to remember. And sepsis 1, which was defined in 1991 by Society of Critical Care Medicines and American Society chapter for critical care physicians. Then again, in 2001, that sepsis 1 criteria was replaced with the sepsis 2 by a surviving sepsis campaign, which is an experts society, which was a few people was grouped together as a surviving sepsis campaign team. The team is going to be called as task force. In their second consensus, they released sepsis 2 criteria in 2001. After 2001 also, they feel that the sepsis 2 criteria also insufficient to define sepsis appropriately. Then they do so much of works, almost all 400,000 medical records, EMRs was analyzed in American and Europe countries, and they came up with a third consensus in 2016, where a sepsis 3 criteria was defined. Here you need to remember our ICD-10 CM was published on 2015 October 1st. It is an effective, but this sepsis 3 criteria was released in 2016. There is a one disparity. ICD-10 CM is not according to the sepsis 3 criteria for sepsis condition. That's why Many people are confused what to code, what not to code, and many denials based on this disparity. And then again, when you try to review, ICD-11 is towards the sepsis 3 criteria. Then what was the changes and all we are going to discuss. Now, what they defined as a sepsis under sepsis 1 criteria. They defined sepsis as a host response characterized into infection. Whatever it may be the response, it is going to as a due to infection. Then sepsis, they defined it as a sepsis syndrome with a clinical signs of infection and the presence of inadequate perfusion and dysfunction at least one end organ. Then again, criteria, they defined criteria like there will be a documented or suspected source of infection plus presence of 2 out of 4 SIRS criteria. That's why many, I think whenever you attended for coding trainings in your initial coding days and all, people will define sepsis is nothing but SIRS plus infection. It was gone in 2001 itself, the definition. Don't follow that definition. Then in 2001, this team of experts was formed as a task force and then labeled it as an SSC, sepsis surviving sepsis campaign or sepsis surviving campaign. They defined a definition to sepsis. They identified that whatever it may be, the SIRS plus infection is not sensitive to define a sepsis, and many patients are missing or over-diagnosing the sepsis than SIRS. That's why they want to change that definition to sepsis 2, and they define the sepsis 2. In sepsis 2, sepsis is defined as a deleterious host response to an infection. Again, sepsis is classified in 3 subsets, and is sepsis, severe sepsis without septic shock, and severe sepsis with septic shock. Then severe sepsis without septic shock means they added one additional parameters to sepsis, like a patient should have organ dysfunction. Then with sepsis plus organ dysfunction is to be severe sepsis without septic shock as per sepsis 2. Then now severe sepsis with septic shock means patient should have sepsis. That means documented source of infection plus any 2 parameters of SIRS criteria, and there should be any one organ dysfunction and a shock, circulatory failure. This is the definition of septic shock as per sepsis 2. However, why we need, since sepsis 3 in the industry and many people are following, why we need to know this sepsis 2 criteria? Yes, let me try to explain. Few payers still they are using sepsis 2 criteria, and few facilities they are diagnosing based on sepsis 1 criteria. This is the major confusions. Like hospitals or providers, they need to update their criteria based on the payers, because they need to get the payment from the payer. We are not going to do like for tracking only, like ICD 10 CM coding is not only for the tracking. They linked with the payment. So you did your services appropriately as a provider. You need to be get an appropriate reimbursement for it. That when payer is following one criteria and hospital is following one criteria, and that communication comes to coding organization in different criteria. Then we need to define any criteria, our criteria according to the payer, what they are following. Then I will let you know one more thing. Since in New York, especially till the time of COVID-19, they are using sepsis 1 criteria only. After that, like a remaining like California and some other states, they used to do sepsis 2 criteria, and remaining states they are using sepsis 3 criteria. Then now, once the COVID was entered into 2019, 2020 as an epidemic, there was a lack of manpower to track the patients and to monitor the patients in early stages and all. Then entire US healthcare, they shift back to sepsis 1 criteria. Then now they are paying according to sepsis 1 criteria. However, OIG, OIG, Office of Inspector Generals, then those are going to monitor the quality of documentation, quality of coding, and errors from the hospitals. They are going to very closely monitor the claims and data. Now sepsis is one of the target diagnosis code for 2026. That means they are going to monitor all the health records, whatever it may be diagnosed with the sepsis. Either they are coding according to the diagnosing according to the criteria which was defined, or they're coding appropriately or not. They are going to monitor, and they're going to coming back to sepsis 3 after COVID episode was closed now. That's why they make it as a targeted condition for monitoring by the OIC. That's why we need to learn sepsis in detail, and we need to code it appropriately, which is going to be a benefit to hospital and the physicians, individual practitioners, and even for payers also. Okay, now we'll try to see how sepsis 2 was defined with the different parameters, and how organ dysfunction can be calculated with the sepsis 2, and how we can code according to sepsis 2. Then criteria was defined parameters into 5 types. One is the general parameters. Second category is the inflammatory parameters. Third one is the hemodynamic parameters. Fourth one is organ dysfunction parameters. And fifth one is tissue perfusion parameters. If you observe here, this is a general, inflammatory, and hemodynamic. Then when it comes to the fourth parameter, it's an organ dysfunction parameter. That means that severe sepsis starts from fourth parameter. And if added a fifth parameter, it will be a septic shock. Now, general parameters was classified into like SIRS criteria again, 3 hypothermia, tachycardia, tachypnea. These 3 parameters was included on the general parameters, and they added some more general parameters like an altered mental status, which should be less than measured by GCS, that should be less than 15, and there should be a significant positive fluid balance, and either hyperglycemia in a non-diabetic patients. Hyperglycemia in a non-diabetic patients. Then inflammatory parameters including that fourth criteria of SIRS, that's a leukocytosis or leukocytopenia. Either WBC count is elevated, more than 12,000, or decreased less than 4,000. Then again, few more inflammatory parameters are added, like an elevated CRP and elevated procalcitonin. Minimum, there should be a deviation more than 2 standard deviations. Then again, third parameter is the hemodynamic parameters from circulatory system. MAP here, MAP should be less than 70 mmHg. Somewhere literature says that systolic blood pressure should be less than 90. Then it's okay. It comes to hemodynamic, like an MAP should be less than 70 only. Then MAP stands for mean arterial pressure. Usually blood pressure values will be, 2 values will be there in a blood pressure reading. One is systolic blood pressure, another one is a diastolic blood pressure. Suppose if you take a normal 120 by 80, 120 is a systolic blood pressure, 80 is a diastolic blood pressure. Most of the times, MAP is not going to be documented by the physicians in your medical record. Then how we need to calculate an MAP? Then MAP can be calculated with 2/3 of systolic blood pressure plus 1/3 of diastolic blood pressure. 2/3 of systolic blood pressure plus 1/3 of diastolic blood pressure. It gives the mean arterial pressure. that should be less than 70 mmHg to define a patient with sepsis. Then organ dysfunction parameters was not clear in sepsis 2 but still few people are following, like an arterial hypoxemia, which will be measured with by P/F ratio that should be less than 300 mmHg. Many of medical records, you may not identify P/F ratios. Physicians are not going to document. Then you need to measure, you need to calculate P/F ratio by reviewing ABG reports if available. If ABG reports are not available, then you need to take it from SpO2 values and supplemental oxygen, whatever patient received. Then you need to, based on those values, you need to calculate your P/F ratio. If it is less than 300, then it is going to be declared it as an arterial hypoxemia. Then oliguria, where patient should have urine output 0.5 ml per kg per hour. Here there is an ambiguity in sepsis 2 criteria. They didn't define for how many days or how many hours or how many times. They didn't define. That's why the sepsis 3 criteria was evolved. And creatinine. Creatinine should be, they specified it as a greater than 0.5 mmHg. Sorry, mg per dl. But while reviewing many records and many literatures and all, people came to know that creatinine increase 0.5 mg per dl should be from the patient's baseline. Now, what is a baseline creatinine? Baseline creatinine generally in normal healthy people, like where person does not have chronic kidney diseases, there will be a stable creatinine which should be normally less than 1.2. We are going to consider it as a normal reference range. Then baseline creatinine means patient is stable at that level of creatinine. Usually physicians, most of the times physicians, they won't write the baseline creatinine. They may document the recent creatinine value. You can take it as a baseline since at that level patient is stable. From that level, suppose assume patient's creatinine was 0.9. From 0.9 to it has to increase by 0.5. That means creatinine has to increase more than 1.4. Then only we need to consider it as a parameter to diagnose a patient for sepsis. Then hyperbilirubinemia, that should be greater than 4. Then coagulation, it has been measured with INR, should be 1.5. Then platelet count, where platelet count should be less than 100,000. These are the organ dysfunction parameters. Whenever there is a deficit, like whatever the irregularities based on these parameters, what will they define? Then it is going to be called as a patient having organ dysfunction. Then fifth parameter is in tissue perfusion parameters, where serum lactate is like a greater than 3 to 4. Then again, moderate skin and like in a capillary, increased capillary refilling time, that should be greater than 3. Greater than 3 seconds. These are the tissue perfusion parameters, where patient having tissue perfusion parameters added to this particular syndrome, then the patient is going to call as septic shock. This is as per sepsis 2 criteria. Then we discussed, right, this. Then after a reviewing of a 400,000 of EMRs, especially, they came to know that this is not sufficient to define a sepsis. What they understood, right, they identified that the patients with an organ dysfunction and infection, some patients, they are not meeting the SIRS criteria. Like what we discussed, there is a documented source of infection plus any 2 parameters from SIRS criteria plus, then only we are going to consider it as a sepsis. Then after reviewing 400,000 of medical records, they identified that though the patient having infection and organ dysfunction, this is a true sepsis, but does not meeting the SIRS criteria due to some other reasons, like a patient using antibiotics, like a prior to investigate it, or prior to diagnose the sepsis, or some medications and all, it's not meeting the SIRS criteria. Then they understood that they need to have an evidence-based and a data-driven diagnosis to define a patient's, especially for sepsis. Then the term severe sepsis, it's causing a confusion again, which was explained in sepsis 2 criteria. Then it was often misrepresented or inconsistently used across the institutions and coding guidelines. This is another parameter where they wants to define a new guideline. Based on the data, whatever they driven, and the task force committee was connected in 2016 in their third consensus, and they decided and declared that a more accurate, a reliable, and clinically useful definitions for sepsis, which was based on evidence-based criteria and a data-driven criteria. Then they introduced SOFA scale to identify the sepsis cases in detail and in a better manner. Then what is SOFA? SOFA is define it as in a full form, like in a sequential organ failure assessment. Then there are many SOFA scales. There is not only one SOFA scale. For an example, if we take a patient with chronic liver failure, then there is another SOFA to assess the patient. SOFA scale is nothing but it's an assessment tool only. Then there is one more tool, SOFA. It's going to be called as SOFA, that is CLIF SOFA, CLIF SOFA scale. It stands for chronic liver failure sequential organ failure assessment, CLIF. So like that, there was a few more scales to because of that reason, they define it as a sepsis related SOFA scale. When to be precise, that they define scale for sepsis and they labeled it as a sepsis related SOFA scale, to be precise. Then we'll try to understand what they did in sepsis 3 criteria. Then, okay, we'll go back one step back to sepsis 2 criteria, how to define sepsis and sepsis 2 and sepsis, severe sepsis without septic shock and severe sepsis with septic shock. Then medical record should be evident for a physician a diagnostic statement of sepsis or severe sepsis or septic shock along with the suspected source of infection. Then patient should meet, or medical record should meet the at least one parameter in either in general parameters, inflammatory parameters, and hemodynamic parameters. Then it is going to be called as sepsis. That means then when patient having a physician documentation, source of infection, and medical record meets the criteria from general parameters, inflammatory parameters, hemodynamic parameters, organ dysfunction parameters, then it is going to be called as severe sepsis without septic shock. Then in a case where medical record is evident for physician documentation with source of infection, then any one parameter from general parameters and inflammatory parameters, then hemodynamic, organ dysfunction, and tissue perfusion. Then only if a patient meets all the 5 one criteria from all 5 parameters, then it is only called as septic shock. Otherwise, whoever pairs following sepsis 2 criteria, they're going to deny your claims. I think it's clear, right? From now, we are going to move from sepsis 2 criteria to sepsis 3 criteria, and we'll try to understand what is the differences between sepsis 2 criteria and sepsis 3 criteria. What was the changes happened? Okay. Now, if you observe, there is a parameters like general parameters, inflammatory parameters, hemodynamic parameters, then organ dysfunction parameters, and tissue perfusion parameters. Then what are the organ dysfunction parameters? They specifically explain in terms of respiratory in arterial hypoxemia, renal system with the help of oliguria, decreased urine output, and creatinine. Then hepatobiliary system with the help of hyperbilirubinemia. Then coagulation systems, like that will be with the coagulation INR and platelet count. These are the systems they took it as an assess the patients for an organ failure or organ dysfunction. Then how this sepsis 2 parameters are converted into sepsis 3, we'll try to understand now. In sepsis 3, they defined sepsis 3 as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. Like Dr. Krishna explained in a very detailed manner how the dysregulated host response and all. But we'll take it in a simple manner. Suppose if I'm having a problem, I went to hospital. Then what a doctor they are going to document? First of all, they will check our vitals, like in heart rate, pulse, temperature, and BP, and some physical examination findings. And they may do some basic investigations like CBPA, CUA, and all. Okay. If still they find any abnormalities and they didn't identify a visible reason for it, then they are going to investigate in deeper layers. They go to deeper investigations to identify the cause. Here, if everything is fine, like my pulse, my heart rate, temperature, and BP, and everything is fine, then it is going to be called as a regulated response to either injury or infections. Then when it is going to be dysregulated, then it's in a huge deviations are in whatever it may be the parameters. Then it is going to be considered as a dysregulated. That means because of the infection, a body need to have a super derangement than what normally a person have. Then only it is considered as a dysregulated. Then it's a dysregulated host response to a specific infection. Then sepsis is explained. The sepsis syndrome is explained in 2 subsets only. When it comes to sepsis 3 criteria, there is only 2 subsets. One is a sepsis, another one is a septic shock. There is no severe sepsis without septic shock. Here we need to understand sepsis with septic shock means it's a severe sepsis with septic shock only. That means whatever it may be, that definition, if you observe in sepsis 2, sepsis, they defined it as a deleterious host response. Then when it comes to the definition to sepsis 3, it is converted as a dysregulated host response to an infection within a characterized by life-threatening organ dysfunction. If you read the definition thoroughly, it's a life-threatening organ dysfunction caused by a dysregulated host response to an infection. That means, like in a sepsis and severe sepsis without septic shock, what we discussed in previous criteria, sepsis 2. When it comes to the sepsis 3 criteria, it is clubbed together and they labeled it as an sepsis. When it comes to the third parameter, third criteria, third one in sepsis 2 criteria, like a severe sepsis with septic shock, they labeled it as a sepsis with septic shock, and they changed the definition. Here, septic shock is defined as a persisting hypotension, which requires an administration of IV vasopressors to maintain arterial blood pressure, mean arterial blood pressure, that should be greater than 65 mmHg. Previously it was 70 mmHg. Now it was to maintain above the 65 mmHg, patient need an IV vasopressors. Apart from that, a patient must have hyperlactatemia in the settings of adequate hydration. I think I pick one example and a sample study to define a septic shock. Try to understand here, to define a septic shock, you need to have two parameters in your medical record. One is there should be a vasopressor requirements to maintain the mean arterial pressure above the 65 mmHg, and lactic acidosis, the serum lactate should be more than 2 millimoles per liter. That means hyperlactatemia. Then they added another adjective here, in the settings of adequate hydration. That means after giving a proper rehydration to the patient, still patient have elevated lactic acids that should be more than 2. Then only it's a patient is going to satisfy the criteria of septic shock. If initial lactate levels are more than 2 or 3 after giving an IV fluid hydration, then the lactic acid is going to be come down less than 2. Then it won't be a septic shock. Here we'll go back to hyperlactatemia again. Body is producing 20 millimoles per kg lactic acid per day, but still it is less than 2 millimoles in the blood whenever you check. Then what's happening? The remaining lactic acidosis was using by the liver in a co-recycle for gluconeogenesis, and your kidney is going to be helpful to excrete that lactic acidosis via metabolisms. Then whenever this both kidney and liver was impaired their functions, they're unable to utilize or excrete the lactic acidosis in terms of lactic acid clearance. Then lactic acidosis is going to be accumulating in the blood. That condition is going to maybe in a lactic acidosis or maybe in a hyperlactatemia. Without having any failure, organ failure, patient might not have sepsis. Then why they are keeping an adequate hydration into the picture? Usually, suppose when you do, we'll take in a simple example. You are running, you are doing an aggressive exercises. What happened? Lactic acid is going to be produced. That lactic acid is going to be excreted in a form of via skin with the help of sweating. That's why you are getting, your body is trying to put you more sweat to eliminate the lactic acidosis. When patient is presented with a dehydration with some sort of mild infection or something, then lactic acidosis is high. When the dehydration was corrected, that means your excretory organs are functioning well. Then lactic acidosis is coming down. Then it won't be in a septic shock. Still, you are producing rehydrating the patient properly. Then your lactic acidosis, lactic clearance was impaired, or still lactic acidosis is high. That means that either a liver or kidney is not functions are impaired. They are not working properly. Then only you need to think about sepsis and septic shock. Because there is certain, we used to call it as any healthcare, it is a core measures. I am going to give you in a few 5 steps. What steps you need to understand and review the medical record to code it sepsis appropriately. If you follow that, you never miss the sepsis and septic shock in your future coding scenarios. Then again, this is the definitions of sepsis according to sepsis 3. Then how they calculate these organ dysfunctions with the help of SOFA scale, we will see now. The parameters are classified into 6 different systems. One is respiratory parameters, which will be measured with the help of V/F ratio. Then coagulation this one, then it's going to be measured with the help of platelet count. Then third one is an hepatobiliary system, which is a parameter like bilirubin. Then fourth one is cardiovascular system. It has our hemodynamic system, which will be measured with the mean arterial pressure. And fifth one is a neurological system, which will be measured with the Glasgow Coma scale. Then sixth one is a renal system, which will be measured with the help of creatinine. This is the basic SOFA scale. Nowadays, people are modifying it with the help of anuria and all, like a decreased urine output and all. Then, however, few payers are accepting modified SOFA scale criteria, and few payers are stick to basic criteria only. That's why I didn't bring a modified SOFA scale here for discussion. Then we'll try to understand. Then this SOFA scale was like divided, like the 6 systems were classified into 4 grades, like in a points, 4-point scale. Then overall 6 into 4, 24 score. Then at least the patient should have elevated in a score should be greater than 2, then it is going to be a sepsis. That much of simple to assess this with the help of SOFA scale while coding in your medical records. It's a very, very simple. Only you need to understand the process and you need to calculate the score appropriately. If it is more than 2, you need not to go for remaining parameters. Directly you can code sepsis. Okay, to diagnose a patient with sepsis, and medical record should be evident, or medical record should be evident for a physician's as documentation of a diagnostic statement and a suspected or a documented source of infection. That means a confirmed source of infection, or sometimes physicians might document sepsis from a respiratory source, sepsis from a digestive source, sepsis from a urinary tract source. That much also enough to code a sepsis because it is a suspected source of infection. Only the thing is, the documentation should be evident for SOFA scale. Then you can code it sepsis. Then again, along with the documentation on source of infection, and medical record should be evident for acute increase of greater than 2 points from baseline score. Here you need to concentrate. That score should be an acute increase of 2 points from baseline score using sepsis related SOFA scale. Then what is the baseline again here? Then if we come down the next table, it's a table showing like in a points from 0, 1, 2, 3, 4 for each system. That's points 0 is in a baseline. Point 0, wherever the 0 values were specified, it is in a baseline. Suppose we will take a P by F ratio only. If it is a P by F ratio is greater than 400 and above 400, either equal and above 400, then it will be normal. That patient score is 0. According to this is an adult sepsis SOFA scale. Adult sepsis SOFA scale. Then again, if it is in a platelet count is like in a 150 or like in a greater than 150,000, again score is 0. If a bilirubin is less than 1.2, then the score is 0. If your mean arterial pressure is greater than or equal to 70, then the score is 0. Then a Glasgow Coma scale is 15, then score is 0. Then creatinine is less than 1.2, score is 0. Then when it is going to be score 1, then any one system parameters is increased reaches the values which are showing at the column 1, under column 1, then the SOFA scale will be total score will be 1. Suppose patients having respiratory parameters is like in a P by F ratio is from 300 to 400, assume, and remaining all parameters are at baseline, like in a platelets are 150,000, Then bilirubin is less than 1.2, like either 0.9, and arterial pressure is greater than 70. Assume it is an 80, and patient is fully conscious oriented, and GCS is 15, and creatinine is 0.9. Your score is only 1 because it is a 300 to 400 only. Then there is no acute elevation of SOFA scale score greater than 2. It's a less than 2, then it won't be a sepsis. Suppose, apart from the P/F ratio, either patient's platelet count was decreased to 100,000 to 150,000. Like either it may be assumed like a 120,000 or 1.2 lakhs platelet count. Then your point, you may get a one more score point here, and the total SOFA square will be 2. Then if it is one more system added, then it will be 3. Like that. Like this, SOFA scale score should be calculated either entire one system will be increased greater than 2, or altogether greater than 2 is enough to diagnose a patient with sepsis. It's clear, right? Okay. Total score should be 24. Then 24, in that 24, patient need to medical elevate that or get the score more than 2. Then only it comes sepsis. Then at the 2 score, what they are trying to explain, that this respiratory rate is less than, P/F ratio should be less than 300. That means 200 to 300. 299, to be precise. 200 to 299, then SOFA square will be 2. Then if it is an 99,000 of platelets to decrease to 50,000, then it will be SOFA score will be 2 for that particular parameters. Then bilirubin is increased like in a 2.0 to 5.9, then the SOFA score will be 2. Then patient's mean arterial pressure is less than 70, and patient put on dopamine at less than 5. Then it will be SOFA score 2. If GCS is from 10 to 12, then it will be SOFA score 2. Then it's a kidney function, creatinine from 2.0 to 3.4. Then it's a score 2. In the same way, you need to calculate till 4. Then you need to club all scores together. Then if it is increased greater than 2, then it will be a positive and evidence for sepsis. Then again, there is one tricky point here. That increase of SOFA score greater than 2 should be an acute elevation, acute derangement, not in a chronic one. We'll take it. Patient having a chronic liver failure. Patient having a chronic liver failure, and his previous bilirubin levels was like in a 2.4. There is no other derangements. Patient's creatinine bilirubin level was 2.4 only. Then you are not supposed to apply this scale at that case, because patient having any previous bilirubin 2.4, now also it's 2.6 or 2, that's 3, but still it's not crossing the score like a 5.9. If it crosses 5.9, then only score crosses 2. Otherwise, we need to consider it as a normal to that particular patient. Suppose there is a huge margin for bilirubin. We'll go with a creatinine. Very simple. Creatinine difference is 1.1, less than 1.2 is a normal. If it is a 1.2 to 1.9, then the SOFA score will be 1. Then assume patient having some other parameter, platelet count was 110,000. Okay, you got one score for SOFA from SOFA scale. Again, you are looking for a creatinine. Creatinine was elevated to 1.6. Patient is a known case of chronic kidney disease. His baseline creatinine is 1.4. That means creatinine was elevated from 1.4 to 1.6. But when you observe the score here, it's 1.2 to 1.9 is the score will be 1. You are not supposed to take that score as a 1 here and calculate altogether. Then patient score is 2. Then it's a possibility of sepsis. That's wrong. That means an acute elevation. In that case, creatinine has to be increased greater than 1.9. Then only you need to consider it as a 1 point, like a 1 score. Total score is going to be increased. Otherwise, you need to consider it as a baseline only. That's why the word, they defined acute increase of greater than 2 points from patient's baseline score. Here people are confusing and raising unnecessary queries, and physicians are most of the times in healthcare, physicians are salary based physicians. They know that whenever a query really is generated, they need to agree that query to increase the payment, that expected reimbursement. They are going to accept your query and you are coding based on that query. That entire claim is coming back in the form of denial. If we stop raising the query unnecessarily, the entire chain is going to be breakdown. Okay, that's why you need to review the physician's documentation. There is some organizations where physicians they took some employees for this particular purpose. Though the physician is not documented, then after a month or 2 months, they are going to raise a query to get a physician is going to approve or accept that query, and they are coding for that particular condition to increase their DRG value. One common concept, physician's main intention to treating the patient at the time of treating patient is to bring back the patient from that particular derangement or disease. That means physician is not documented sepsis in his record, means sepsis is not presented to the patient at that time. Sepsis is out of his physician's mind, since it is not there to the patient. If it's a patient having sepsis and sepsis foci, he will document. Then we are not supposed to, as a coder or as an auditors, we are not supposed to bypass the physician and raise a query to challenging his clinical knowledge and clinical decisions. When really there is an ambiguity and physician forgot to write it, then you can raise a query based on these parameters. Otherwise, please try to avoid raising unnecessary queries. Those are going to be impact your hospital or your provider's quality of ratings. Then when providers' quality of ratings are going to be decreased, then next year patient's base payment value is going to be decreased. When base payment value is going to be decreased, the expected reimbursement is going to be decreased for entire hospital, not for one DRG. Okay. Then what is QSOFA? We discussed about SOFA and we'll try to understand QSOFA. Especially QSOFA stands for Quick Sequential Organ Failure Assessment. Then it's a 3 points tool, like based on like what Dr. Krishna explained. Patient should have an altered mental status. It should be less than 15 GCS. Then respiratory rate should be greater than 22. It's called a tachypnea. Then a systolic blood pressure of less than 100. Then only that to this quick SOFA, then patient should have at least minimum 2 parameters, satisfy minimum 2 parameters to say that the patient having a satisfied with QSOFA. Then what is the use of this QSOFA? QSOFA is going to be an assessment tool. There is an early prediction of sepsis, the possibility of sepsis, or if patient getting the satisfying the QSOFA on outside of ICU or other than the ICU, then patient requires an ICU stay to monitor for SOFA, like a sepsis. To assess the patients in that way, only QSOFA will help us. But some people, the QSOFA is only for assessing the patient's prognosis or monitoring tool only. It's not a diagnostic tool. Remember, it's not going to help you to diagnose a patient with sepsis. But still, few organizations like coding organizations and few revenue RCM organizations, they are taking this QSOFA and they're arguing that the patient having sepsis in denials. That's also not appropriate. It's just a screening tool, not a diagnostic tool. Then it is less sensitive to than SIRS also. And it may miss an early sepsis if you follow QSOFA. Then again, it mean not mean to replace the clinical judgment, physician's clinical judgment or full scoring of SOFA scale in ICU. Now, this is what I told you, no? This is a classical picture. If you want to practice this classical, like a 5 steps tool, then try to remember this and you review the medical record according to this sequence. Then you may never miss the sepsis and septic shock. This is called as CMS defined, and this surviving sepsis campaign adopted, and CMS adopted this tool to diagnose the patients appropriately in ICU settings, in hospital settings especially. Then it's going to be called as 1 hour bundle, sepsis 1 hour bundle. Previously it was a 3 hour bundle. Then they deducted all together, make it as in a 1 hour and make it as in a 1 hour bundle. Usually we can say it as in a core measures. Core measures are going to help you to understand a disease process and how physicians diagnosed, how accurately they diagnosed. Then you need not to raise a queries. You need to know the core measures. Each and every disease have a different core measures. Then now we'll try to understand these measures too, like a 1 hour bundle measures for sepsis. These are defined based on a set of evidence-based interventions, and all the clinicians and experts, they decided all the activities has to be done within 1 hour, not in 3 hours. That's why they clubbed together. Then this goal is to rapidly stabilize the patient and reduce the mortality. If really patient having sepsis, by this 5 steps, if at the end of this 5 steps patient having sepsis, they are going to treat it. If not, any one step they missed, that means that this is either sepsis or septic shock was ruled out. Okay, we'll try to understand. So first hour, 1 hour bundle, that may be patient may be in hospital or presenting to the hospital. Suppose patient is in ICU, he admitted for something else, now monitoring for sepsis. The point where physician get in a doubt or suspicious to sepsis, that point from that time to 1 hour, they need to do all these activities. Otherwise, patient presented to the hospital in the ER itself, physician suspecting sepsis. Then like an arrival time to the ER, from arrival time, we need to take it as in a 0 second, and you need to observe the activities which was happening in sequence. Okay, we'll see. First and foremost, whenever physician suspects a patient with sepsis, they need to collect any samples for lactic acid. They will collect a sample and send it to the lactic acid. Monitor just to identify. Then it takes time, like 1 hour or 2 hours. Then go to your lab reports and see the initial lactate level. If it is greater than 2, then simultaneously they will take samples for cultures also. Then you move to cultures. If the cultures are positive or negative, it's not good. They are not going to impacting the diagnosis and coding, but cultures are going to impact the treatment and like which antibiotic has to give, which patient have with resistance levels and all to monitor for that. It helps to the physician. Then third level, try to observe. any administration of antibiotic, broad spectrum antibiotics was given or not. If they given broad spectrum antibiotics, then you're going in a right way to code sepsis. Then check on a fourth level, like an administration of IV fluids, because the patient having hypotension. By that time, you review the medical record, you come to know patient having hypotension. Then identify the IV fluids, how the physician was advised. It's in a rapid rehydration, either with the colloids or crystalloids and all. You need to identify. Then we can come to a conclusion. Then, if your serum lactic acid, initial serum lactic acid is greater than 2, then look for another level. Check monitoring the timings also, like a sample collection timing and all. You need to identify. Then, if a sample collection, second sample which was collected after rehydration and still it is greater than 2, then simply you can quote sepsis and septic shock. You need not to worry about the remaining documentation part on that. Anyhow, physicians, these type of events was happen means physician's mind is to treat the patient on as a sepsis only. He will document it, mandatory. Then blindly you can quote sepsis and septic shock. Suppose second lactate levels it came less than 2 after administration of IV fluids. Then still the remaining parameters was there. Then it could be only sepsis. Septic shock is not there because after hydration the lactic acid levels was less than 2. Then there's a one. It's not meeting the criteria of septic shock as per sepsis 3 criteria. If you follow these steps, it will be helpful to you, and you will never and ever miss the coding of sepsis and septic shock. This is available in internet with the SSC 1 hour bundle for sepsis. If you type it, you can download this. You can take a print and can keep it in your desk. It will be helpful to you to code it appropriately. Then treatment. I think Dr. Krishna has explained very nicely about an administration of IV and broad spectrum antibiotics and whatever it may be the local infections. That was the focus of sepsis. It has to be treated appropriately. Like if it is an abscess, drainage it, and infected catheters, remove them. Infected IV lines, remove them. Then provide a supportive measures to cope up from the organ dysfunctions or failure, like a renal replacement therapy, oxygen supplementations, and IV fluid administrations, and all. If it requires vasopressor administrations for septic shock. All these things will be there in your medical record. Only the thing is you need to follow step by step to understand the medical documentation and code it appropriately. And one more thing, like conditions like sepsis and especially in inpatient settings, either you are doing coding for any inpatient claims of a physician or facility coding or whatever it may be. If you don't understand the physician's documentation, or just you are thinking that the coding is whatever the physician documented, you need to go and check the alphabetic, like in alphanumeric codes and coding. It's merely waste. Coding is an art. Medical coding is an art, and it's a collaborative effort between coder and physician. If we don't maintain that collaborative effort, then we may not code it. We may not become a good coders, and that facility is going to lose at work certain period of time. Then try to we'll take in a short time, like in a 2-3 minutes, and go through this case 1 and case 2, and let me note it down yourself. Then we'll see the results. This one I'm going to read now. A 35-year-old female patient presented with complaints of fever, burning urination for the past 5 days. Then past medical history is positive for diabetes. On examination or during the hospitalizations, vitals was heart rate at 98, respiratory is at 22, temperature at 37, BP 90/60 on presentation, and improved after 100 ml of 1000 ml of NS. Then GCS at 15, SpO2 at 98% on room air for the entire stay. Then WBC is 12,400 on day 1 and 10,000 on day 3. Then platelets are 140,000 on day 1 and 165,000 on day 3. Then creatinine is 0.9 on day 1, 0.6 on day 3. Bilirubin is 1.1 on day 1, 0.8 on day 3. Blood cultures are no growth. Inflammatory parameters like CRP elevated, procalcitonin negative. Lactate is less than 2 millimoles per liter. And urine is evident for pus cells at a 30 HPE. And leukocyte esterase is positive. And urine culture is positive for E. coli. Physician, when it comes to the diagnostic statements part, HNP was documented with sepsis with UTI, septic shock, and diabetes. And then initial progress notes was documented with sepsis and UTI, DM. Then when it comes to the discharge summary, then physician documented as an urosepsis and DM. This is the case 1. Try to list out parameters and use this scale and try to calculate SOFA scale, SOFA score with the help of this scale. Take a minute or two, we'll move to next case. Okay, shall I move to second case? So second case is a 65 years old male patient presented with a productive cough and fever for the past 1 week. Now presented with a severe left-sided chest pain. Then obviously when there is a severe left-sided chest pain, the patient should have some sort of breathlessness, which was not present, not documented here. Because of pain, that number of respirations are going to be restricted. Then patient will have some sort of breathlessness. Then past medical history is evident for DM, hypertension, and CKD. So patient's recent creatinine value was 1.8. The recent creatinine value 1.8 can be considered as a baseline creatinine. Okay. Then during the stay, vitals was like a heart rate is 124, respiratory rate is 28, temperature is 38.4 degrees centigrade. Then BP is 80/50 on presentation. Patient is drowsy, GCS at 13. Saturation, SpO2 is 86% on room air. Then placed on 5 liters of oxygen. Okay. And labs were evident for WBC 12,400 on day 1, 14,800 on day 2. Then it is decreased to 12,600 on day 3. Then platelet counts 100,000 on day 1, 165,000 on day 3. Then again creatinine 2.1 on day 1, 2.4 on day 2, 1.6 on day 4. bilirubin is 1.1 on day 1, 0.8 on day 3. Just I bring whatever the parameters which required to us to assess the SOFA score, because there's a lack of space and all. Then blood cultures was negative. Serum lactate was 2.8 at the beginning, initial serum lactate. Then it was 1.6 after 1000 ml of normal saline. And then chest X-ray was evident for left lower lobe consolidation. Sputum have no growth. Then when it comes to the statements, diagnostic statements, documentation part, medical record is evident for initially patient was placed on dopamine and then weaned off after an hour. Then HNP is evident for HNP and initial progress notes was evident for pneumonia, respiratory failure, sepsis from LRTI, septic shock, hypertension, diabetes, and CKD. Then progress notes and consultation notes, discharge summaries are evident for documentation of pneumonia, sepsis, septic shock, hypertension, diabetes, and CKD. I think you picked whatever the parameters are required to you to identify the sepsis by calculating the SOFA scale. Then we'll move to SOFA scale again. Then now take a 1 minute or 2 minutes time to assess this SOFA score.
Hari, we do have the response total score is 8. For second scale, for responses, they have mentioned total SOFA score is 8.
It's great. Okay, we'll move. This is the results. First case, it's the physician document, though the physician documentation of sepsis. And then he documented source of infection also. But the SOFA scale is equal to 1 only. That should be less than 2. Then there is no sepsis for patient. If you go to the parameters, all are like even 90/60, it comes, though it gives mean arterial pressure is less than 70, but immediately patient was improved. GCS is 15 and even platelet count is 140. 140 is gives only 1 score. So there's no sepsis for this patient. When it comes to the second, it's in SOFA scale, we calculated it's 8, okay, fine, because it's more than 2, we can code it. Exactly where you went for 8 is, creatinine is here 1.8 baseline creatinine. When you go to the scale, it was 2.4. You take directly, I think you taken directly as a score 2. But you need to take it as a from baseline, it's only 1 score only. That you need to correct yourself from next charts. Then the SOFA scale is around 7. Yes, patient having sepsis, but there is no septic shock. Since second lactic acid, after dehydration, lactic acid was less than 2. It does not meet the criteria of septic shock. Even inotropes also, what we saw with the inotropes was withdrawn or weaned off in an hour. That means by getting the second lab report of lactic acidosis, we came to know lactic acidosis was reduced and patient's blood pressure was improved, not required. In that way, you need to review the medical record and identify the appropriate clinical indicators and select a code. confirm either the patient having that particular diagnosis or not. Still you are facing an ambiguity, you feel that there is an ambiguity, then you need to raise a provider queries for getting clarifications. Okay. Then we come to like an ICD-10 coding. It's a very short of time. I think people know very well about coding guidelines, and I'll just I'm touching few areas. And use a correct code for underlying systemic infection when diagnosing a sepsis. And if the infection type or organism is not specified, code A41.9 as an unspecified sepsis. Even if blood cultures are negative or unclear, sepsis can still be diagnosed based on the clinical evidence. Always confirm with the provider. If the patient has a sepsis with an acute organ dysfunction or multiple organ dysfunctions, follow the guidelines for coding severe sepsis. Since ICD-10 is according to the sepsis 2 criteria and the industry is according to the sepsis 3 criteria. There is one disparity between here, but however, we don't have any other coding system to handle according to sepsis 3 criteria. As a coder, we are following severe sepsis and severe without septic shock whenever it is possible. However, there is any other additional MCCs or CCs, this particular R65.21 or 20 especially, it comes as a CC. It becomes a CC, it is not going to impact your DRG assignment because since there is an additional comorbidity, either urinary tract infection or a pneumonia or something else, then an acute infection was there, then it's not a matter. It comes to the either the player is following sepsis 2 or sepsis 3. Only when the problem is you are assigning septic shock code. Septic shock code becomes an MCC. If it is your chart does not have any other MCCs and you are assigned a septic shock as an MCC, if the septic shock is not validated in the medical record, your DRG is going to be downgraded and paid accordingly. Then, if a patient has sepsis and acute organ dysfunction, but the documentation shows that the organ dysfunction is caused by another medical condition, here we are not supposed to code a severe sepsis. Either severe sepsis without organ dysfunction or severe sepsis without septic shock or severe sepsis with septic shock. You are not supposed to code under this. Then to assign the severe sepsis code, the acute organ dysfunction must be directly linked to the sepsis by the physician. If not, please raise a provider query or provider clarification for it. Sepsis versus septic shock. Septic shock generally refers to a circulatory failure associated with severe sepsis, and therefore it represents an organ dysfunction, acute organ dysfunctions. Then for cases of septic shock, the code from the systemic infection should be sequenced first. Since sepsis need to be sequenced first, followed by R65.21, severe sepsis with septic shock or any post-procedural septic shocks. Any additional codes for acute organ dysfunction should also be assigned as noted in the sequencing instructions in tabular list. The code for a septic shock cannot be assigned as a principal diagnosis. Here we need to come, like in what we discussed, right? This point you need to be remember. This is the area where commonly denials are coming. While coding itself, we need to be follow this. Like again, if the patient having to decide either the patient having an acute kidney failure or not, we need to follow KDIGO guidelines, and based on the guideline only, you need to select an appropriate code. Okay. The guidelines you can get it from the internet. If you search with the KDIGO, you can get the guidelines. Sepsis versus localized infection. Then we need to code sepsis first, followed by localized infection, and then pneumonia, cellulitis, or whatever it may be. If a severe sepsis was present, then there is severe sepsis, septic shock, without septic shock, you need to assign additional codes. This is a coding clinic guideline. I think provided documented like a Klebsiella sepsis without septic shock due to acute pyelonephritis. This is the same example to that particular previous guideline. Whenever there is a systemic infection followed by sepsis followed by localized infection, we need to code systemic infection with sepsis first, followed by localized infection codes. This is a sepsis complicated pregnancy and puerperiums. Always the codes from O categories, O series codes, O chapter, like obstetric codes or pediatric codes comes first, followed by the sepsis type of infection, sepsis and other organ dysfunctions. This is in supporting that particular guideline. Toxic shock syndrome, here it is you need to identify some sort of difference. Usually sepsis will be used first whenever there is an infection and all, but toxic shock syndrome is a different entity which is more specific than sepsis, unspecified. There is a document like a sepsis unspecified organism with a toxic shock syndrome. Toxic shock syndrome is more specific than sepsis with unspecified organism. We need to code sequence toxic shock syndrome as first, followed by sepsis. Usually, this toxic shock syndrome signs and symptoms and criteria very similar to sepsis only. It will be like due to streptococci and staphylococci bacteria. It is more specific than the sepsis unspecified organisms. Toxic shock syndrome first as a PDX, followed by sepsis. Then again, what we discussed till now is sepsis is a infectious process. Then we have a guideline in sepsis associated with non-infectious process. Here people will get a doubt. If a non-infectious process, whatever it may be, the response has to be coded as a SIRS. But why the guideline was created in ICD-10-CM? That means whenever the guideline explained like a sepsis associated with the non-infectious process, that means if you understand it properly, that non-infectious process leads to an infection, that infection leads to a sepsis. If you come to in a retrospective way, by the time of physician specifying a sepsis, the non-infectious process was added with the superadded infectious pathogens. That infection was severe and the patient developed sepsis. In that case, depending on the circumstances of admission, you need to code it as which condition has to sequence first. Either sepsis need to sequence first or the non-infectious process sequenced first. It should be depending on the circumstances of admission. Like either the sepsis is present at the time of admission or developed during the admission, hospitalization. Based on that, you need to sequence which one has to be sequenced as a principal diagnosis. It's the same, especially this is a classical example, aspiration pneumonia with sepsis. That means aspiration pneumonia was converted to pneumonia. Pneumonia leads to the sepsis. In that way, you need to understand and code it up. Then these are the common challenges. Sepsis, like where this these challenges was listed out based on the denials. Okay. When a patient is admitted with both sepsis and localized infection, sepsis is sequenced first, and the localized infection is sequenced as a secondary diagnosis. Then sepsis is eligible to code it as a principal diagnosis. That means it has to be presented by the time of admission. These are the common errors what we identified. Sepsis are signs and symptoms of sepsis not present on admission. And sepsis is not going to be the principal diagnosis in that case. Post-procedural sepsis or sepsis due to a device or implant has to be coded to the appropriate complication code sequence first, then sepsis code. In that case also, sepsis would not be a principal diagnosis. Sepsis was not the principal reason for admission. Not supposed to be sequenced as a principal diagnosis. That means by the time of admission, sepsis patient does not develop sepsis. Then this is another classical example for COVID-19. This is the same what we discussed from the particular criteria, like people, different hospitals following different criteria and different payers following different criteria. Some hospitals' responsibility to create it, especially providers' responsibility, but providers automatically they throw that responsibility or transfer that responsibility to the coding organizations. Coding organizations need to escalate it and make it sure what criteria they are using at the facility level. And if there is a difference between payer and provider facility level, we need to sit as a coding organizations, we need to sit with the provider and fix it and need to follow the same guideline for future coding processes. These are the best practices to avoid denials. The entire medical record must be reviewed and you need to identify the scope and limitations of each and every document in the medical record. If a condition which was documented as a presentation of at the time of admission and initial progress notes, that condition is not appearing in the discharge summary and the other consultation notes, it was not consistently documented in the discharge summary. That means you need to understand that the condition was ruled out and which is not eligible to assign a code for that particular condition. Identify a diagnosis and procedure codes from physician's clinical documentation appropriately. Applying rules for whose documentation counts first for coding purposes. That means where an ambiguity between two providers' documentation, like a consultant and attending physicians, a consultant and ER physicians, attending physician and ER physicians. These documentations having ambiguity. You need to know whose documentation need to be taken precedence for coding purposes. When always attending physician's documentation takes a precedence, still if it is an ambiguity, use a provider queries to the attending physician, get a clarification before assigning the codes. Arriving at the correct codes and assign appropriately. That's it from my end for today. We have questions, please discuss those.
Wow. Hari, am I audible?
Yes, yes.
Hello. Yeah.
Yes, yes.
Thanks, Hari. Wow, Hari. So, what an incredible session. You have shared the knowledge on the sepsis and clinical documentation. That is truly enlightening, Hari. And you presented the information in such a clear and detailed manner that even someone new to the US healthcare system could easily grasp it. You have explained each scenario with clear documentation, examples, how it is affecting in US healthcare, what are the guidelines we have to follow, everything. It was very wonderful. We are truly grateful to have you had our speaker today. Okay. On behalf of the AAPC Hyderabad local chapter, we will be presenting you with a speaker certificate as a token of appreciation, and also you will be rewarded for your valuable contribution on this session. Once again, Hari, thank you so much. Thank you for sharing such a rich knowledge with us today. You truly brought immense value to everyone who attended the session. We sincerely appreciate your effort and expertise. Thank you for taking the time to educate and inspire us. So
Thank you, Madhuri. Thank you all.
I hope everyone you enjoyed the session and you grasped a lot of knowledge on sepsis and its clinical documentation. Yeah, so now let me check if there are any questions in the group. It's time for the Q&A. Then we do have a surprise, guys. Like as mentioned by Funny, we will roll out the quiz to test your knowledge. Okay, and I hope everyone who participated the session, you will take the quiz, and the top 5 participants who answered the questions correctly will be rewarded. Once we are done with the Q&A, we will roll out the quiz. So, Pani, there are a lot of questions in between the session. Okay, so I'll go through with the questions and you can share your answers here. The first question is, can we code without documentation of septic shock from the workup or lab values only?
No. In that case, if medical record having a clear picture of septic shock or clinical indicators, it's in a one area of improvement, like if to coders, where they need to raise a provider clarification form or provider query. Then once you need to get an acceptance for your query, once physician agreed, then only you need to code it. That means like when physician was not documented septic shock, but still medical record is evident for clinical indicators.
Okay.
That means
So
it's one
based on
area
indicators, we cannot take the decision. That should be documented by the provider. Okay. Thank you, Hari. There is another question. What if the patient had liver cirrhosis and CKD and the baseline value is not known? Can we consider the lowest reading during hospital stay as baseline?
Some textbooks they are telling that we can consider. Otherwise, you need to review that like in a medical record, like where the patient having a previous values prior to admission, like in where like previous admission values and all. If those values also not available, we can take it as a lowest values during the hospitalization as a baseline values and calculate retrospectively.
Okay.
Okay.
Okay. So
for this, I will take one example.
Yeah,
for this, I will take one example. Acute kidney failure, usually in case of CKD patients, patient having CKD like a stage 3 or stage 4, we don't know patient's previous creatinine values. Patient presented to the hospital and physician documented as an acute kidney failure. Then how we need to validate it? Usually, during the hospital, you might have any values. Initially, in this scenario example, patient will have high creatinine values at the time of admission. Then once the treatment progresses, the creatinine is going to be decreased to a baseline or normal. At the time of discharge, but prior to time of discharge, whatever it means the creatinine value, whichever the lowest value, you need to take it as a baseline value. And you need to analyze it in a retrospectively. Suppose at the time of admission, creatinine level was 2.8. Then during the stay, like a prior to discharge, it was in a lowest value is 1.4. Here, what guidelines suggest is, in this case, retrospectively, that should be creatinine increased into 1.5, like in 1.5 times to the baseline creatinine. Here 2.8 in 1.4 our baseline. If 1.4 base into 1.5 times is a 2.1. Then patient having acute kidney failure in this case. You need to analyze it retrospectively.
They have to utilize their knowledge here.
Yes.
Whatever we have learned, they have to apply those knowledge to take the decision. So there is one more question, Hari, that is, we discussed about some parameters, right? So the question is related to, as a coder, how these parameters will be useful for us.
So either as a coder, right? Very good question. What is the purpose of coding? Coding is purpose is not to assign some alphanumeric codes and throw the case from our bucket, right? The main intention of the coding is to get an appropriate payment, get an appropriate reimbursement. When we'll get a reimbursement appropriately without any denial, if you understand that, if you coded it appropriately, according to the clinical documentation, you need to code it appropriately, then only that claim is going to be paid. Then you to analyze it. The physician, he might document sepsis, he might document septic shock. Then what your seniors or what your mentors, somebody they tell you, you need to review the entire medical record one time. If even the physician documented at once, you need to code it. That is the coding practice what we have in the industry. Physician was documented sepsis or septic shock in the beginning, at the time of presentation. It was not at the time of discharge summary. Initially, we used to code all the conditions from discharge summary, and we'll come back and starting reviewing from HNP. Whatever the conditions they listed, we'll try to code it. Coder's mindset is to avoid audit errors. If you don't give, then auditor don't know that these conditions, these conditions was need to consider as a ruled out. They will mark an error. To avoid those error markings, then coders will assign, though there is a one-time physician documented. You need to know, as a coder, we need to know either it is a part of differential diagnosis or is a part of assessment, continuous assessment physician was documented. Then we need to think about it. Why physician was documented in the previous visit, previous day notes, and why he was not documented in the current day notes. Is there any parameters was changed? Or suppose physician was added some other condition. Suppose beginning at the time of admission or during the HNP, physician not documented sepsis. And second day or third day, physician documented sepsis. That means at the time of admission, patient does not have any septic patient. At that time, it was not evaluated. After study, that means after getting all lab reports and all, physician come to a conclusion that the patient having sepsis. Then he documented on the second day or third day. As a coder, if you don't know the parameters, then you may not have any idea why physician adding these services and all. That's why you need to know the parameters, clinical parameters, basically. At least what are the signs and symptoms? What is the criteria we need to have?
Thank you.
Whatever I talked about, right, coding conventions, point 19. You go and read the statement. Till 2022, it was stating that the physician's documentation is sufficient to code in a particular condition. That the criteria is not required. From 23 onwards, 23 or 24 onwards, they added one statement at the end of the particular guideline. When a physician documentation is not clear or there is no clinical support, then you need to raise a query. To raise a query, you need to know what is a supporting documentation in the medical record. Those are the parameters. You need to know those things. There is no way to escape it. As a coder, if you want to sustain in the coding industry, we need to know, because AI is going to disrupt the even coding industry also. Then we are not supposed to replace it by AI, means we need to be can learn and we need to be ready with it.
Sure, Hari. So we will know all the parameters to do accurate coding and avoid denials. Thanks for your insights, Hari. Hari, there are a lot of questions in the group, but as we are running short of time, we will consolidate and share the questions to you. Once you check and share your insights, we will share it in the LinkedIn group.
Sure, ma'am.
Okay. Yeah. So, guys, now it's time for quick knowledge check. I hope everyone is ready to test your understanding of the concepts we have just covered. Let's see how much we have absorbed. Good luck, guys. And again, I am reiterating you, the top 5 participants who answers the questions correctly will be rewarded. So give it your best. This is your time to shine. Okay, Funny, over to you to share the link to this group.
Am I audible?
Now you are audible. Yeah.
Okay, so we have shared the link in the chat box. So this is the quiz link. And if anyone is not able to access the chat box, you can get into the AAPC Hyderabad WhatsApp channel. So I have posted in the channel also. And this link will be active for 30 minutes. So this is obviously, as I mentioned, it should be a fastest finger first. Whoever answers first will be the correct answers, and the first answers, first 5 will be rewarded. So we'll be in touch with you with the details that you provide in the form. And
Yes,
we will
please
also
do not share your details in this chat box. We already considered your attendance to registrations. So I request everyone to open the forms links and answer the Q&A. Please do not share your personal details here. If you are unable to open the link, we have shared the link in our WhatsApp group. I request everyone to go back and check our AAPC WhatsApp channel. There also you have the link. You can access from that.
we already see the responses are coming. The link is good and accessible.
Funny, if you are requesting to share the WhatsApp channel link here, could you please share it?
Sure.
Guys, regarding your CEUs, we will work in the backend. It will take couple of weeks to add your CEUs to your member IDs. Once we are done with that, we will give a confirmation in our social media. In our AAPC WhatsApp channel, we will confirm and we will share the same information in our LinkedIn channel. Still, if you did not receive the CEUs, you can reach out to us. We will share our AAPC email ID here. If there are any concerns, please send us an email. We will check and we will respond to you. Yeah, here is the WhatsApp channel link Funny has posted. If anyone you are unable to access the link from this chat box, I request everyone to access the WhatsApp channel link. There you can get it. Yeah, Reddy, if you are done with the Q&A, everything, you can leave. Funny, do we have anything to cover?
No, Madhuri, we are good. So I just wanted to mention everyone, we have the event coming up in the July. Second week, we will have one event. And then on the August, maybe first or third week, we will have one more event. So we will have multiple events coming up. And there will be at least one event every month. So please try to be active. in the socials. We will share if there is any event. We will share the information in our WhatsApp channel. Okay. So that's it. So the link will be active for 30 minutes. And yeah, so that's all we have. Madhuri, unless if you don't have anything, then we can close. And thanks to our speaker for giving such a valuable, insightful session for all of us.
Thank you, Hari. Thanks, Funny. That's all we have from our end today. Happy weekend, guys.
Thank you all.